Okay. So, what made you want to become a psychiatrist?
I think part of what made me want to become a psychiatrist was exposure in earlier life to an actual psychiatrist.
Hmm.
A close family friend was a psychiatrist and seemed to have a really nice balance of both sort of life satisfaction and life balance, but also seemed to really enjoy his job.
Okay.
And he seemed to, just be fascinated by his own job and really, upbeat about it, not counting the days to retirement.
Okay. Okay. What kind of characteristics do you think are important for someone who is hoping to succeed in this field?
For someone who's hoping to succeed in psychiatry, I mean, you have to be interested in people.
Hmm.
A long time ago, I had a trainee who left the program tell me that she just did not like talking to patients. And that's, this is the wrong field if you can't find human beings very interesting.
Yeah.
Because that's a big part of what we do is try to, almost play like detective to sort of figure out what's causing someone to
Hmm.
be going through whatever they're going through. Um, and what was the question again?
Sure. Characteristics that are
Oh yeah.
important.
So yeah, interested in people. I mean, it helps to be a good listener, which doesn't mean you have to be silent always,
Yeah.
but at least hear the other side of the equation. Whether it's an active conversation with a patient or using silence more as a therapeutic technique.
Okay. And then what can you say about like someone's demeanor, sort of like how they approach situations or kind of things like that, like someone calm or someone like things like that.
Yeah, I think in general it helps to have a calm demeanor
Mhm.
because you'll be presented with folks as a psychiatrist who are feeling suicidal or feeling aggressive, and you don't want to try to influence any of those sort of emotional states. But you also, I mean, in the older form of psychiatry with everyone sort of Sigmund Freud, I mean that was a little bit more of a blank slate, emotionless face kind of psychiatrist. That's not necessarily the way it is today. I mean, you can show some emotion as long as it's appropriate to the situation.
Hmm.
But what I always tell students is you never want to be the only one laughing with a patient. If they're not laughing and you're laughing, that's not good.
Yeah.
But depending on the situation, you may cry with a patient or laugh with them, but it has to be really in sync with whatever the patient's going through.
Okay. And so as far as satisfaction, I know obviously like especially looking into it, it's kind of daunting, like from my perspective of getting into a field like psychiatry. And so after getting through all of that, are you happy with the work you're doing right now? Are you satisfied with your job every day?
Yeah, I'm satisfied with the job I do. I can't really imagine having done anything else. I think any job has good days, bad days, pluses and minuses. But I would say that most of the interactions I have with patients are fulfilling. Even as a child psychiatrist, everyone always asks me, do the parents drive me nuts? And I would say the large majority of parents are very helpful and they're fun to work with. But there are exceptions. They can make things a little trickier. But in general, and I think also compared to other doctors I know in other fields of medicine, I feel like in general psychiatrists have a really high um, satisfaction rate. Maybe because we get to spend the most time with patients, we're not quite as rushed in our daily schedule, and our hours are typically more reasonable. So I think there are a number of reasons why there's less burnout perhaps in psychiatry.
Yeah. And just kind of out of personal curiosity, I know like a big part of it is medication, and there's also the therapy,
Mm-hmm.
psychological treatment. Like what kind of balance do you see between the two of them when you're interacting with patients?
The pendulum has swung to some degree a little bit more towards medication.
Hmm.
Although, at least what I do, I mean, I think if someone's a really bad psychiatrist, they could see someone in 5 minutes and write a prescription and be done with it. All of my follow-up patients I spend about up to 30 minutes with, and I spend about an hour and a half with new patients. So that's a lot more time than you have necessarily in other fields of medicine. And within 30 minutes, a little bit of that might be attention to medicines, but I would say just as much attention is really more to sort of diagnostic challenges, trying to figure out anything that might be helpful.
Hmm.
And then I'm almost like the quarterback of the team. Like I'll call the plays. I'll say, you need to go get a speech and language evaluation, or you need to pee in a cup and do a urine drug screen because I think that there may be something here that's unspoken. So a lot of it is being very sensitive to all the different contributors. But as far as actual intervention that I deliver at this point, it's most often medicine. Although I do sort of what's considered sort of cognitive behavioral therapy, sort of light in a time limited span. There are some therapeutic techniques, but I'm not typically doing the hour-long weekly therapy that you would find with a psychologist.
Refer them to other people.
Often refer to other people if they need more intensive therapy.
And so when you make those analyses, when you're with patients, are you just talking to them to figure that kind of stuff out, or are you like looking into their past? Is there like any specific things you do?
You're talking to the patient. Partly you're getting their own self-report, You're getting historical information like family history, of course. I mean, anytime you evaluate a patient, you're asking psychiatric history, family history, medical history, allergies, current mood state. You do maybe a mental status exam where you might ask them questions about memory, attentional capacities, stuff like that. But then, especially with children, you need a lot of additional collateral information. So I might talk to the school, talk to the parent, talk to the daycare provider, talk to the probation officer for some of these teenagers. And then there are also different sorts of scales you can give folks. You know, they're validated norm reference kind of scales. So they might have a ton of kids fill out this depression scale with known depression, so they get an idea of what kind of scores do kids with known depression have, and then you give to other kids to figure out, is this child experiencing symptoms that are consistent with a likely depression. So I do a lot of work with scales, or once again referring to other providers for more in-depth educational testing, psychological testing. I can order laboratory tests. I will sometimes order a sleep study, or I will order blood tests for anything like thyroid hormone, anemia, etc.
Okay. And so when I was kind of like looking up people who would want to get into contact with, I was reading your page and it said you were child/adolescent psychiatrist. So what age groups is that specific to?
Pretty much, it's atypical for me to see anyone under the age of 3 years old.
Okay.
Because I really think it's hard to determine psychiatric things at that age, and if it's really obvious by the age of 2 that a child's autism, usually we rely on the pediatricians to make that initial screening if it's that straightforward. But I joke that I pretty much see folks anywhere the age of about 3 years old up to about 30 years old. I mean, in some ways, college these days, med school, even out of med school, is almost extended adolescence in a way. Our brains aren't fully formed until we're probably mid-20s or late 20s. So a lot of issues I see with the college students I work with, because even though I'm a child psychiatrist, it's not like pediatrics, where if you turn 18, you get kicked out of the clinic. I'm still seeing patients that I saw originally when they were 13, and now they're 24, 25. So you don't really age out. But patient population I like working with the most are teenagers.
Okay.
I probably see mostly 13 and 14-year-old kids. But what's nice about them is that in addition to the parents helping you with their story, they're old enough that they can have an individual sort of relationship with their psychiatrist also. Let parents leave the room, and then you also work with the child individually.
Yeah. And so what does your place here at MSU have to do with that? Like, do you meet with patients here at an office, or do you have a separate one that you deal with, like the younger kids and stuff like that?
For the patients that I see in this clinic, we meet with them right here in my office.
Okay.
But then most psychiatrists here, including me, we also operate in other settings. So a day and a half a week, I'm working with children out in a trailer park population, Medicaid population, out in Stanton, Michigan, not too far from Greenville, Michigan. Yeah. And so I'll drive out there every Tuesday, about an hour and 20-minute drive each way. Enjoy the drive because I listen to audiobooks and whatnot. But I've been working there for about 11 years, and all day long I'm seeing kids that are below the poverty line. So that's it's a different sort of bag of pluses and minuses, but there's many rewarding things about doing that too.
Okay, all right, thank you. Let's see, I derailed there a little bit. That's not important. So obviously, going into the study of psychiatry, you have some initial assumptions, and there's things that you think about the profession. And what is different now being a psychiatrist from what you thought about it beforehand when you were starting schooling?
I think one thing that's different, I think going into it, I knew that we had the ability to help folks some, but I think since my initial exposure was so much in the inpatient settings and with folks with chronic schizophrenia and those issues, I guess I didn't fully appreciate how much of an impact we can make, especially with kids, because most conditions are very treatable. I expect most of my patients to really get back to life, be almost 100% again, or 100%. And so I think I underestimated how big an impact you can make, especially with the younger population, as far as getting back to full health. People do get better, which is really nice, and I didn't fully appreciate before. I also appreciate, as I said earlier, about that parents are more enjoyable to work with. I think they're really an asset to have on the team when you're working with kids. And I think I also appreciate more now about how pervasive mental health issues are in our society. What such a large percentage of children, teenagers, college students have anxiety, depression, substance use issues. I think on the surface we don't realize how many folks struggle with those issues. But once you become a psychiatrist, partly because you treat a lot of folks, but also because a lot of folks confide in you, even if you're not treating them, when they find out you're a psychiatrist, that you realize, like, wow, a lot of folks, even really high-functioning folks, deal with these issues.
Okay. Let's see. how do you cope with the emotional load of so many different dealing with so many different people's problems? Do you like take things personally, like you sleep well at night, things like that?
Yeah, that's a good question and one I'm asked a lot. I think initially it's a little tougher when you're first working with folks who are depressed or anxious or hearing voices or suicidal. But I do think eventually, almost like what would happen with the emergency room doctor, you do get a little bit thicker skin as far as being you're more used to it, which doesn't mean that you're not feeling. But I think, if a situation, if a patient is angry right in front of you or crying right in front of you, you do have a little bit of clinical distance as far as saying, okay, what does this mean? What is their crying tell me about where they're at? Or how can I try to comfort them or intervene here? So it gives you clinical information. I don't necessarily go home feeling depressed, although occasionally if there's a really extreme case, of a child being abused or something like that, then you do take that home a little bit more. But I think in some ways I'm almost better equipped to deal with some of those issues than some of my friends that are family doctors or pediatricians, because I feel like I know how to manage those situations pretty well. Whereas my friends in the other professions, they're dealing with those situations without having had the expertise. And with them, it sort of jumps out, and I think, and startles them and surprises them because they don't know, if a patient with a chief complaint of chest pain is going to end up actually talking about abuse, where I, in general, have a pretty good idea of what kinds of issues might be presenting. Okay. So I don't think I take it home too much, but in extreme cases, sure, it could be something to deal with.
All right. How did you end up where you are now professionally? It's like what led you to this point after going through school and kind of things like that, like why MSU?
Yeah.
Here?
It's a long process. I went here as a medical student to College of Human Medicine. Had a really good experience here. Thought it might be nice to return to this kind of environment, and I really enjoyed my time in East Lansing. So, plus also knowing that I like to work with adolescents and also college students, this is a perfect setting. But I had the idea that I did not necessarily want to see just patient after patient just day in day out as the only thing I did. I really like the idea of being involved more in teaching and development of curriculum, things like that I think are fun. I teach the psychiatry course for the second year osteopathic students. And, I incorporate video, movie clips, trivia, different stuff into our educational process. I created some online modules that have, pop-up quizzes and YouTube videos and stuff like that I think can make psychiatry a little more interesting, at the same time still teaching the core kind of stuff. But as far as getting here, this is my first job out of residency. But residency takes, if you do a child fellowship plus residency, it's a total of 5 years. So if you figure it's undergrad plus at least 4 years of med school, plus at least 5 years after that, and then after that, all that schooling, then I popped into this job. And they're still on-the-job training. You learn to teach as you go along by going to seminars, by doing your own reading. Nobody really teaches you how to teach when you're a doctor, so that's tricky. So the educational process never ends, and there's always new medicines, new things to learn. So it keeps it interesting, but you're never like fully arrived. But that's okay because it would be boring, I think, otherwise.
Yeah. And so you talk about the long process that I'm also aware of. How difficult is it? Like, is it manageable? Like, I like to think that I'm like, this is more like a personal question. Like, I like to think I'm a good student at good grades, but like, how feasible is it for someone without like a really strong like chemistry sort of background to sort of like come in, teach themselves things, and succeed?
Yeah, I don't think a strong science background. I mean, I think, of course, you have to do prerequisites to get into medical school. So everyone has some science, but I've had friends that are Russian majors, that are English majors, folks that really did not do science majors that have done very well in medical school. And I think there's some truth to the fact of, getting into medical school is fairly difficult, but once you get in, there's a very high matriculation rate. We expect easily for, far over 90% of our students who enter to eventually become doctors. So, I mean, that's a lot better than the chances of, pre-med folks necessarily going to medical school. Although the good news is that there are a lot more medical schools in the state of Michigan now than there used to be. And they're both, MD schools, DO schools. There's lots of options. So I think actually, the chances of getting in these days is probably not any worse than it was before. Although I think the applications have gone up at the same time that the number of spots have gone up for medical schools. The tricky thing is that the number of residency spots in the hospitals has not gone up. And so we might actually find that sometimes folks that get into medical school but that are our lowest performing medical students might have a tough time in the future maybe getting a job out of medical school. Might be a weird limbo land they get stuck in. It hasn't happened yet. In psychiatry, it probably wouldn't happen for a long time because we're a very underserved area. There's still a big need for psychiatrists, so I don't think that's going to get saturated anytime. real soon. But I would say that, anyone who's good enough to get through undergrad and have our average GPAs now are probably, over a 3.5, and MCATs are, a certain level typically. If you're around those marks, I don't see why someone couldn't do it. Because I think the schools really want you to succeed once you're in med school, as opposed to undergrad where I think they want you to succeed, but they aren't invested in each individual to have to be pre-med or something. It's just they want you to succeed in general.
Okay. Let's see. So, how much free time are you allowed with this profession? Like, do you see it as enough, or do you feel overworked ever?
I feel that I have enough free time. I feel like my balance is great. You do have to get used to saying no sometimes. I mean, if you were someone that said yes to everything, if someone says, please, would you mind lecturing to our group next week? And would you mind taking on another course? Or would you like to take on these 10 new patients? I mean, you have to say no some. Otherwise, you'd be overwhelmed. But I think as long as you're able to say no at times and say yes a lot of times too, then you can work it out. I have 3 children, and my wife and family, they never complain about not seeing me. I'm probably almost too available sometimes, like for lunch or other times, and they have other stuff going on. So I don't feel like I've missed anything at all from other aspects of life. I've even had time, in addition to seeing patients, to have hobbies like, writing, and getting published and having some of these other things. So it's nice to spend time for other things. But I can't say that's true of all doctors. But I think some of it also is self-fulfilling. If you sign up for something where you're going to work 80 hours a week, then you work 8 hours a week. If you do a profession that has a little more better balance, there's no reason why you can't have a life that is somewhat similar to other lives. My life is pretty similar to an 8 a.m. to maybe 6 p.m. at the latest typically kind of life, and that's a pretty normal life.
Okay. So what was the transition like for you from finishing your residency to coming here? Was it sort of like you were a shoo-in, or you had to apply and you were pretty sure you're going to get in, or like what was that like for you?
The nice thing about once you get through all the doctor stuff, and it's long, it's a marathon, not a sprint. But I think if you are really focused and motivated, you get through it all, and then eventually you really are guaranteed a job. It might not necessarily be the job you love. A lot of times I joke that the jobs that are advertised the most for doctors are probably some of the worst jobs. They offer a lot of money, but they're tough jobs. But in general, once you finish, you'll have a lot of folks approach you, even before you finish, residency. A lot of folks approach you, whether you're a psychiatrist or any kind of doctor, offer you jobs and wanting to fly you places and show you around, and you'll have a lot of job offers. The tricky part is just choosing the best job for you. What I even did is I just cold called some places, Michigan State included. They were not advertising for a job when I was interested, and just sort of cold called and just sort of said, would there maybe be some job opportunities opening up? And so what's nice is if you are a physician in an underserved profession like psychiatry, just even getting the word around that you are a graduate looking for employment, places might be able to think about job creation. So that's really nice. And I always say that with psychiatry in particular, especially child psychiatry, it's one of the few kind of jobs where you can pretty much work anywhere in the country. I mean, I think I could even probably go today to Manhattan, New York, and get some sort of a job. And that's typically an area that's saturated for almost all kinds of jobs. I don't think some of my friends that are surgeons could go necessarily to Manhattan and set up shop. So I think it's nice being in a profession that there's a lot of folks that need serving, but it also makes you feel good from a marketing standpoint and from a personal standpoint to be needed and to know that there's a lot of need for my services.
Okay. Let's see. So like what is an average day for you here? Say like in this part, or even like the days over you said you spent in Stanley.
Yeah, fortunately, even though there's a routine schedule, each day varies somewhat, which is nice. But a typical week for me is, and it's fairly regimented, is Monday mornings I see my own patients. Monday afternoon I do a telepsychiatry, which is almost like a fancy Skype that's more secure, where I see kids over the airwaves. There's a nurse with the children in Stanton, Michigan, and we work that way. And I just click the button, boom, and the prescriptions go over to the pharmacy. And then on Tuesdays, I'm there in person at the mental health center. Wednesdays is more administrative, putting together lectures, supervising residents. And then for 2 half days on Thursdays and Fridays, I actually sit behind the glass often and watch our training doctors see their own patients. So I'm armchair quarterbacking that way. And then I also, discuss the cases later with the residents. Sometimes intervene if there's something that needs immediate attention. And then teach classes in between. It depends on the semester, but do small groups, lecturing, curriculum development, all that kind of stuff.
Okay. I get all over the place with these questions here. How has being a psychiatrist changed the way you think about psychiatry?
I think being a psychiatrist has changed the way I think about psychiatry. In terms of, it helps you understand all the stuff that we do know about the brain and appreciate that we do know a lot of stuff or have a lot of ways to intervene. But at the same time, you also see how there's, so much more that we don't know. The brain is such a complicated organ. I think we were hoping that mapping the human genome would help us just lay it all out and we'd be done. But there's still a lot more mystery as far as the mind, as opposed to just even the workings of just the brain. So I'm glad that we have a lot more tools these days than we used to in the old days. 30 years ago, we maybe just had a few medicines, 2 or 3 medicines that we threw at everything. Now it is more nuanced, but we still need more tools. Like for things like schizophrenia and Alzheimer's. Hopefully there'll be even greater developments down the road. So I appreciate we know a lot. Still a long way to go.
And just out of curiosity, you work with lots of kids. What kind of conditions do you see that are prevalent among children, or is there anything really surprising things that people wouldn't expect kids of that age to have?
For children, if you're talking about children that are maybe prepubertal, things on my radar typically are things you might expect, like ADHD, learning disabilities, autism. Although some cases of autism, if they're more subtle, can be tricky to tease out. Anxiety disorders can pop up in kids pretty young. You can already have kids as young as 6 years old with OCD. You might see a fair amount of Tourette's or tics kind of issues in young children. You tend to see a little bit older. You can see depression occasionally in a really young child. Usually that child's been through some major early life trauma kind of issues, maybe some PTSD. But then once you hit puberty, suddenly you have a lot more kids with major depression, anxiety, eventually maybe some bipolar disorder, but that's even typically probably a little bit later in the teens. And I don't see much schizophrenia. Although occasionally I'll have folks with a first break of psychosis in their late teens. More often that those are folks that are probably about college age or older when they have the first break with that. But the only major surprises I would say is that you see a lot of kids with unexplained headaches, stomach aches, a lot of different somatic things or just falling out or things that no one can explain medically. And often there's maybe some anxiety or depression sort of behind some of that somatic stuff.
Okay. So what would you say is the best and worst part of the job you have?
Best part is relationships. I like being an outpatient psychiatrist because I get to know these patients really well over time. You get to see them longitudinally over time to see how things change. You get to see improvement. You also see sometimes recurrence of issues. But it's nice on many levels, partly because it's a nice relationship, but it also, frankly, makes my job easier or allows me to do a better job. Because if I know the patient really well, I'm a better at reading sort of, what's the best way to help this person. So that's nice. If I've seen a patient now for 11, 12 years, sometimes just the way they look, appearance-wise, I can tell a lot because I've seen them before, in different snapshots over time. So that is one thing. That's one of the best things. One of the toughest things, and I sort of alluded to, is, sometimes having limited ways to help. If the chief complaint, chief complaint meaning the main reason why someone comes to see me, we call it chief complaint. If the chief complaint is aggression, the medication interventions aren't the greatest, and even the therapeutic interventions are so-so, so that's tough to help. Or if there's a child that's been abused and traumatized at a young age, that's a really tricky situation to help. So I think there are many situations where I feel like I can be of a lot of help, but it's also frustrating when there's a situation where people expect you to help or expect you to fix things easily when it's a really complex situation.
Yeah, okay. And then just kind of wrap things up, is it worth it? Are you, would you recommend that I do it if it's something that I'm passionate about, which I am?
I think it's definitely worth it. I think even more than that, I think it's the journey of figuring out for each individual, what's the best fit. I think this for me is a great fit. I don't know if it's a good fit for everybody. And thank goodness there are other kinds of doctors because we need surgeons, we need family doctors. Only 5% of folks who go to medical school end up going into psychiatry. So you're in the minority as far as the profession you choose. But I think the best way to try to figure that stuff out is to get exposure like this interview you're doing. If you end up going to medical school, there are opportunities to shadow psychiatrists. Patients often like to have students sitting in the room with them. A lot of students I know are at first are a little bit hesitant about, do patients not like that about sitting in on these sessions? Most patients really enjoy having students. So there are opportunities to shadow psychiatrists, especially during medical school. And then during medical school, you already get your feet wet and you actually get to see, actual practice. You get to be in the hospitals, in the outpatient clinics, in the emergency rooms, seeing folks. And that's another way to get some more data, because eventually you're going to have to try to make an informed decision based on, your own interests and what your exposure has been to whatever field of medicine.
Okay, that sounds good. I really appreciate it.
All right, yeah, you're welcome.
I gotta say, it's very, very informative.
Oh, good.